just start, if Devin doesn't mind, with a quick 1-minute story as an introduction, because we actually have been here before, and it's a sort of lest we forget. We've been here before at the cutting edge of medicine. I was there, and AstraZeneca, where are they? Hello, guys. You were there too. And what I'm talking about is approximately 30 years ago, with the introduction of the aromatase inhibitors for the treatment of ER-positive breast cancer. So a slightly different bunch of people, slightly different bunch of patients. Look, do you know what? In those days, I remember very clearly, I was a research fellow, and we were looking at MCF7s. These were cells, immortalized cell lines from breast cancer patients that were ER-positive. And we were treating them with the SERMs, hey? So you'd have a flask, and you'd give your patient a little bit of estrogen, add in your SERM, and see what happened. And a lot of these cells died, but a couple of them continued to grow over the times. And over a week or two, you'd land up with a nice full flask full of cells that were resistant to tamoxifen. And we had nothing for those. We had a couple of other SERMs, maybe, raloxifene, tibolone. You guys may remember that. We even, if you were particularly brave, had some of the early aromatase inhibitors, the non-selective ones. Does anybody remember aminoglutamiide? Yep. Well, if you gave that to your cells in the flask, it didn't work that well because it only inhibited the enzyme about 60%, but dear God, if you gave it to your patients, you would put them in ICU. Okay, so it wasn't a great thing. And then AstraZeneca came up with a game changer. They came up with a third-generation aromatase inhibitor that actually suppressed the enzyme to like 97% of its efficacy, thereby totally suppressing estrogen in postmenopausal women, and it worked. I remember very clearly stripping the serum to mimic this activity of anastrozole in a postmenopausal patient, putting it on my cells, going home, and coming back the next morning, and the cells were dead. And it's the rest they say was history, but it went through the third line, second line, first line, and now we're so blasé with this drug. Hey, it's our standard of care, both in adjuvant and neoadjuvant. But 30 years ago, this was groundbreaking stuff. And you won't believe it if you weren't there. I have to say, I think we're there again today, and this is for a slightly different group of patients. It's the HER2 positive patients, and then that group of patients that's up till now has been very poorly served by medical innovation, and that's the HER2 low patients. And to tell us about it today is Dr. Devin Moodley. Now, Devin, as we all know, needs no introduction. I don't know about the rest of you, but I'll come to listen to what Devin has to say, no matter what he's coming to say, because I'm going to listen to Devin, because it's going to be good. Okay, but just in case you don't know, Devin has a private practice in Fitz Donald Gordon Medical Center, and his primary interest is in the treatment of breast cancer. Devin, we all know as a wit, a raconteur, a bit of a joker, but none of this can actually, this bluster can hide his perspicacious intellect and his deep and love-abiding passion for his patients. So, Devin, the stage is yours. Take us into the future.
Thank you, Irene. Thank you, move this. Okay. Yeah, thanks. So the customary disclosure of interest slide, I think some of you would have seen this before. It's most important thing is the last statement is not true because this is a sponsored event. Okay, so just for you to know in terms of interest, declaration of interest. Okay, so in this process now, we kind of need to overview HER2 positive breast cancer, and it's about 15% of the cancers we see. There's either amplification or HER2 protein overexpression, and when you have this in the breast cancer patients, it's linked to a more aggressive phenotype. And what that did is it provided us a valid target to manage these patients, okay? And so you're dealing with, there's your percentage of patients that we look at. And what has happened is since the advent of this target, there's a plethora of other targets that have become available for us to use. And with that expansion in terms of targets, is an expansion in terms of therapies that hone in on those targets. And for that reason, this is quite a cool and sexy field to play in and to have treatment for. And on that basis, we say, okay, this is worth doing. So, HER2 positive breast cancer. HER2 in breast cancer goes on an IHC basis all the way from no staining to 1+ to 2+ to 3+. Okay, and the 3+ staining is what we used to call HER2 positive, and on the basis of that 3+, we used to treat people with targeted anti-HER2 therapy. Okay, now the interesting thing about that 3+ is we have a South Africanism, and that South Africanism required us to confirm that 3+ with a ish of sorts. And that was dictated to us by the funders, no one else. Okay, and largely because there was a learning curve in terms of how good we got at diagnosing 3+. And I remember one of the earliest presentations done at SASMO, strangely enough, that showed that at that point, the FISH, which was then the gold standard, which is far long been surpassed by so many better methods of quantifying HER2 positivity, versus IHC, was associated with roughly, believe it or not, a 59 to 60% concordance. And on that basis, we had a whole lot of funders in the audience, and they said, that's it, we need a FISH. Okay, and that's how that came to pass. Unfortunately, many of the funders have not gotten past that yet, and so we always have to do a FISH estimation. So patients that were HER2 not staining by IHC or 1+ were characterized as negative, and then HER2 positivity was characterized as 3+, and there was a small group within the HER2 2+ that could also be classified as overexpressors. And for that group, that's where we needed to have done better testing. And so you're looking at that group and you find that that was the equivocal group, and some of them turned out to be negative and some of them turned out to be positive. And that's how we got to who's positive. And actually, there's no such thing as positive. There's HER2 normal. Okay, but we started saying those patients are HER2 positive and the other patients were HER2 negative. And that's how we got to that point as to who gets treated and who doesn't get treated. So in the metastatic space, and that's all the drugs start out in the metastatic space before they graduate to earlier phases of disease treatment. The metastatic patients are the patients where we cut our teeth on how these drugs are treated before we escalate them further along the timeline or the therapy pathway. Okay, so we investigated in the Cleopatra trial as to, in the first line, what happens when you treat people with trastuzumab plus chemotherapy versus a doublet, trastuzumab pertuzumab with chemotherapy. And if you look at the PFS and OS, we can see that adding pertuzumab gives you a benefit, an undoubted benefit, and that's seen in both survival and progression-free survival. So having said that, there is something here in first line. But we had a fair number of patients that progressed even after first line, okay? Because in essence, metastatic breast cancer is not curable, right? And because it's not curable, although these patients may last a long time, they come to a point where that initial therapy kind of runs out and we need something else. And what became established in that scenario is the first ADC we started playing with, TDM1. Okay, so the next trial was the Amelia trial, which was used in second line HER2 positive breast cancer, which compared lapatinib, capecitabine, which became the de facto standard of care in second line, versus TDM1. And we can see here that there was a benefit. There was a benefit for one of the first ADCs we started using. And that benefit was significant over this drug. So we had a situation where the standard of care in the first line was a doublet plus chemotherapy. The standard of care in the second line became TDM1, or what we call now Kadcyla, because it's commercialized. And then the third line, we didn't really have consensus. And what happened is the therapy got dictated to by what was actually funded. So some patients got a change of chemotherapy and a maintenance of the targeted therapy. And indeed, the people that sold the targeted therapy, particularly the trastuzumab, had some data that showed that you could actually just change the chemotherapy and you could jog those patients along for a while. Admittedly, it wasn't great data and they couldn't finish the trial. Most patients didn't get enrolled, but that's all we had to go on. And the combination of lapatinib and capecitabine was okay, it worked, but it wasn't great. We battled to get patients through those therapies. So somebody came up with a fancy drug, a fancy ADC, trastuzumab deruxtecan, TDXT. Okay, what it is it's got three parts to it. It's a humanized HER2. It's got the same amino acid as trastuzumab. It's covalently linked to a topo-1 inhibitor as a payload. Okay, now this inhibitor is 10 times more effective than the irinotecan that you give patients. Okay, and then the third part is it's got a little a peptide that joins the two. And the interesting thing about it needs the acid medium to cleave the peptide. Okay, so all your patients that are now swallowing enos because they want a bicarb medium, tell them if you want an ADC, you kind of need the acid, otherwise it's not going to work. And that's an easy sell, right? So the payload is a topo-1 inhibitor. It's a high potency. It's got a short half-life. It's got a stable linker, and it is tumor selective. So what happens then is we started investigating this drug in metastatic breast cancer. And this is a phase 2 study. And initially, Destiny 1 was first part is dose finding, and then it's a phase 2 study. And what happened is, it's quite funny, but they found that most of the patients they gave this drug to, they actually responded. Okay? And they responded so well that what happened is that the registering authorities like the FDA gave them approval, providing they get the phase 2 data. So they got early approval on the basis of what is in essence firstly a dose finding study, and then looking at side effects. So it doesn't happen that often, but it does happen, and the FDA have become more lenient, but still, it's actually quite interesting that that's how they got initial approval. Okay, but at any rate, so first line, doublet plus chemo, second line, Kadcyla, and now third line, let's investigate TDXT. So the investigative registrations trial is Destiny 3. Okay, and the study design was just simple head-to-head, TDM1 versus TDXT. Okay, now what's the difference between the two? Both of them are ADCs. The one had an antimicrotubule as a payload, and the other one had topo-1 inhibitor. Okay, the concentration was 8:1 versus 3.5:1. Both of them had the rest of the stuff that's same. It's got a cleavable linker, and it's a bystander effect. That means not only does it kill the cell it targets, it also kills a few cells in the vicinity. Okay, so it works quite well. Okay, again, this is the obligatory slide that shows that if you look at the experimental arm versus the control arm, they're quite balanced. They're balanced for all criteria, including age, ethnicity, also hormone receptor status, because about half of these patients in both arms were estrogen receptor sensitive. Okay, brain metastases about 20%, and visceral disease about 70%. So you can't say you're stacking the deck with good prognosis patients. These are not good prognosis patients. So in essence, what they find by independent central review, that the experimental arm was much better than the control arm being TDM1. And you can see, you don't even need to sit at the front of the class, you can sit at the back of the class, and the curves separate quite significantly. Okay, and if you look there at the OS, there's even survival benefit. Okay, and if you look at comparing the patients, you can see the bulk of the patients that got TDXT responded. That's how come the entire waterfall plot looks that good. Okay, what's that? Niagara Falls. Okay, so what that gives us at the end of the day is this is how we're looking at managing HER2 positive metastatic breast cancer. Okay, so in the first line, we're going to use a combination plus chemotherapy. In the second line, we're going to use TDXT, and then in the third line, there's all that stuff. Okay, now this is what happens in the first world. This is not what we're going to be able to do, largely because that in there, we don't have tucatinib normally, we don't have naratinib, and we certainly don't have that one. Okay, margetuximab. Okay, so this is what we're looking to get, and we should get some of that soon. So yes, there'll be availability, and the second part is it costs 1 or 2 rupees. So costs always come into it, and then the medical aids bleat. And so we end the standoff that although there is good therapy, and therapy that significantly improve survival, we don't have access to it. So what we look at doing is, number one, access programs, number two, clinical trials, and that's how we get our patients these therapies. And indeed, that's what we've done with even this molecule, the HER2. So that is HER2, quote unquote, positive disease. What about HER2 low? Well, remember I told you about that group? Well, that group was never targeted before because that group said you were HER2 negative. So they would either fall under the luminal, which is ER-PR positive, or if they were negative, they'd fall under the triple negative. Okay, so that's where we'd put those patients before. But wait, if you buy now, you get chicken wings. Okay, so they're no longer fitting in those groups. They rather now are HER2 low. Okay, and the HER2 low is that significant, there's 60% of patients. So here's your small problem in terms of forecasting budgets for medical aids. Okay, please take that in the reckoning when you people decide how much you're going to charge for this drug, because 60% is a lot of patients. Okay, so a lot of patients are going to be up for this drug. And it's, remember, I can bet anything you want this is going to be walked up to second line pretty soon. Okay, so that's what we're going to land with. And first line, next. Okay, metastatic. So just remember that. So what used to happen is this used to be either hormone receptor positive or negative, and hormone receptor positive, well, that we give hormone blocker, hormone blocker, hormone blocker, hormone blocker. Okay, and the hormone receptor negative, that we give chemotherapy. And so Bernardo would talk for years in this half. Okay, because he can, right? So those were the two things we do with this. So we now have what is affectionately known as a kind of new category in this whole breast story. Okay, previously that's how we did it. And so we now have a solution for something that's clinically an unmet need. So how does this work? So that's a simple explanation for how it works. Firstly, the ligand binds a receptor, then it's internalized. Once it's internalized, the linker is cleaved to release the topo-1 isomerase inhibitor, and then that implodes that cell, and it implodes the cells nearby because it's membrane permeable. So it's actually very cool. This is a sexy thing that happens, right? And that's what it is. So we now have a situation where we say, okay, let's see what it's like if we give the other patients that have some HER2 staining, but is not overexpressed or not amplified. What happens in them if we give them this drug? Okay, and what did we have before that? We only had chemotherapy. We had nothing else. That was the standard of care. So that's what this trial tested. It tested TDXT versus physician choice treatment. Okay, and you can see what they use. They use capecitabine, they use eribulin, they use gemcitabine, they use paclitaxel and nab-paclitaxel, which is representative of what doctors or prescribers were doing in this group of patients. Okay, and just a note, they allowed hormone receptor positive disease there, and appropriately so, those that were considered hormone receptor refractory. So this is exactly the kind of patients we'd give chemotherapy to. So they subjected those to the ADC, and you can see that the demographics are quite balanced across both groups. And fortunately, they've described that the progression-free survival in hormone receptor positive and all the patients were better, right? So now you got this large group of patients and we've got a drug they can use, okay? And it's a poor prognosis group of patients because they fitted in the triple negative, which we all know do poorly once they're relapsed, and they fitted in a group of hormone receptor positive patients who exhausted all their hormonal therapies. So this is a drug that worked well in both those patients. And what about the survival in all patients? It was also positive. So a drug that worked in terms of PFS and OS. Okay? And what about in patients that were hormone receptor negative? Well, we can see there that in hormone receptor negative, bearing in mind it is exploratory, they were also associated with benefit. So a drug that worked well in negative patients, in HR positive patients, and in all of the group together. Okay, so generally a drug that works in this group for which we have only chemotherapy, nothing else. Okay. So, yeah, good drug. So, what do we have to worry about? Well, it comes at some costs. The first thing is there are issues with hematology. Okay, so you can drop platelets, you can drop your HB, you can drop your white cell count. They can get nauseous. Okay, and I've got a slide that says you should give them as you treat for chemotherapy. They should get a 5-HTT. They should get maybe some steroid with it, and they should get some aprepitant with it, or whichever epitant you use. Okay, so that's true. You can get fatigue. I mean, you've seen this often with the previous ADC. They can get quite tired. Okay, I've got patients on Kadcyla. They battle for 2 or 3 days afterwards. Okay, they feel like they've been hit by a bus. And we keep ignoring it and saying, it's a monoclonal. I have patients walk in for the monoclonals and leave. There's a little bit of chemotherapy attached to it, and that makes a big difference, okay? And then a couple of good things, patients' weight come down in a quarter of the patients, and there is hair loss, okay? The patients don't tend to go bald, but there is hair loss, so you need to counsel patients. Women hate losing their hair, whether they're young or old. Don't care what you say, they don't like losing their hair. There's a few of us that like our hair chopped off. Most people grow their hair, it's now a fad. They even got little ponytails. The men, I mean, so you can imagine. Right, so if you look at the pooled analysis, you can see that pneumonitis is something that is real. Okay, now, small problem here is that this is not something we commonly see. Yes, we used to see it in chemotherapy in a very small group of patients, and every time we got pneumonitis, when I gave patients chemotherapy, I had to go and look, does gemcitabine actually give you this? Does the taxane actually give you this? And like there are reports of 200 or something in the whole world. Okay, but pneumonitis is something we had to check. It's only when the fancy HER2 blockers and the CDKs came into play that we actually bothered looking for these things. And everolimus. Okay, so this is not something that's common for us. So you have to look for pneumonitis. It's a known risk factor. The problem with pneumonitis can kill you. So it's just to have a high index of suspicion. And when you're doing the scan, you need to tell the radiologist. Okay, otherwise they're going to call it disease progression. Or sometimes lymphangitis. Okay, so it's just important to know. So what can I tell you about this disease? Okay, they have not only improved outcomes in HER2 positive, they've also improved outcomes in new population, i.e. the HER2 low group. Okay, and we've identified a whole new targetable group. It's the first anti-HER2 targeted therapy in these groups of patients. But this is an evolving space, okay? And we need better biomarkers to see who gonna do the best in these scenarios, because 60% of those patients getting HER2, I'm afraid very few economies in the world can manage that unless you come up with a really good plan. Okay, so that's going to be a problem. So it's important to identify who's gonna benefit the most from these ADCs. And then the other thing is, watch the space. There's an anti-HER3 agent, which is actually excellent. And all of these, they bind to all of the patients, whether they 1%, 1 to 25, or 25 to 50 to 100, it works. So the space is just expanding at a rate of knots. Remember I talked about nausea and vomiting? We need to pre-medicate as we do for chemotherapy. Okay, so they need like a 3-drug regimen, like you'd manage CINV and proper antiemetics. Okay, they have unique toxicities. These unique toxicities are number 1, nausea and hair thinning. Number 2, inflammatory lung disease, interstitial lung disease. And remember, if you get the interstitial lung disease, you must stop the drug. And we have to keep an eye on the heart, okay, because of Topo 2. So many questions remain. And without doubt, we're going to get many more drugs that work in this space. Okay, one of the questions is, if you've got similar drugs on ADCs, will the one work if the other one stops working? We don't know. What if the payload is the same and the antibody is different? Will that make a difference if you give them second line? We don't know. Might, because you might be targeting a different group of patients. Okay, and if they work, which would be the best way to combine these drugs? Which one first, which one second? Do we give them together? So I think the field is expanding, and that's great. I think if we're lucky, there'll be many more clinical trials, hint, hint, that we will have access to for our patients. And thank you for listening.